Thank you very much, Joe. So good morning, everyone. Thank you so much for inviting me to talk about the Nightingale learning system that we built in the Excel Centre in the London Field Hospital earlier this year. My name's James Mountford, and my day job at the time was in the Royal Free, and I now work in NHS England and Improvement as the Director of National Improvement Strategy. So it's been quite a year in terms of doing lots of different things. It's also quite an interesting time to be thinking about Nightingale hospitals as we face the autumn surge. And I'm very aware that people, particularly in the north of England, are readying their Nightingale hospitals. And these hospitals have got different clinical models, as I'll describe. Ours in London was an intensive care unit. But I hope the principles that I'm going to talk about are really ones that are irrespective of the clinical model, and they're about how we learn well. And the thing that I hope we're going to take away from our experience in London, and indeed we already are in a number of settings, as I will describe, is how we can build learning into doing on a daily basis in the NHS. And I think that will be greatly to the benefit of staff and patients. So I want to step through a little bit of background to the hospital, give you an overview of the learning system, and then have plenty of time for questions and discussion. So if you go to the first slide, Joe, think back to March. This is Florence Nightingale, and it's around 200 years since she was born. And Florence Nightingale is a very apt person for the Nightingale hospitals to be named after, because some of you might know that Florence was not only the founder and the pioneer of nursing, and there was nothing more important to our patients than the quality of the nursing. And it was a privilege to work with such fantastic nurses from all over London there. But also she was a pioneer of measurement and quality improvement. And therefore of learning. And so I think it's very apt that Florence was our moniker. And indeed, the Nightingale wards, so the sort of ward I first worked in when I was a house officer, was a Nightingale ward in Winchester, big open space, big open corridors. And that was the setup, as you'll see, in the London Nightingale. So we go to the next. This is what I saw on the morning of the 26th of March when I first went on site. If you've been to a conference at the Excel, these are the massive exhibition halls. If you've ever been to the BMJ IHI International Forum, that's down at the far end in the smaller segment of the building. So what feels like a massive conference to me is in the smaller part of the Excel. And these halls are about 1/3 of a mile long. You'll see in the picture there, in the army fatigues, Eamon Sullivan, who was our chief nurse. And Eamon and his army colleagues, Eamon's regular job is in the NHS, but it was absolutely fantastic to work with the army, different parts of the British military, including the Royal Engineers. They are outstanding colleagues in terms of how they lead and how they all set direction and work to a common purpose. And I think it would be fair to say that the NHS colleagues learned a lot from them during the course of our work. So we face these big open spaces. And the really interesting thing was that, to me, this was pretty scary. But to the army people, they said, well, we've got a roof and there's no one shooting at us. So let's go. If you go to the next slide. This just gives you an idea of the setup. You can see Eamon here again, but those big open Nightingale wards and the bed area on the bottom right, and there's the oxygen supply going in for what was to have been a several thousand bedded ICU. Unfortunately, we never needed to get to anything like that scale. If you go to the next, this is a very rare photo of the ward in operation. And I'll just invite you to look at a few features here. So one of them is that it's a sea of blue, everyone in PPE, really hard to tell who different people are. It's quite a bright environment, perhaps a little factory-like. And I'd also like you to just notice the chair at the end of each bed. We'll come back to that in a second. If you move to the next. So this is our learning system, and I'm going to spend a little time describing why we built this and what it did. So the purpose of the Nightingale was to save lives and to protect patients. And the way in which we did that was to be, first of all, really, really clear about our aim and our purpose. So save lives, protect London, and in doing that, look after the staff who are looking after the patients. And that is extremely helpful in terms of deciding what we know and what we don't know and what we need to focus on. So the first thought about parallels to normal life is it's often much less clear, and perhaps we need to spend a bit more time in that more tricky environment of usual life about thinking what good looks like and what we're trying to accomplish. But from that mission clarity of the Nightingale flowed the learning system, which was the same as the operating system. So if we just work around that diagram. So firstly, we gathered data, and we took multiple sources of data. If you just go to the next slide, you can see that there were 9 key sources of data that we brought in. And the point here really is that we tried to get all the data that we needed in order to make planned changes to our system of looking after the patients and the staff. But only the data that we needed would we collect. So it's rather unusual compared to many models of healthcare data, in that you can see there's qualitative and quantitative data here. You can see there is what you might call risk and governance data, as well as what you might call improvement data. And there's data about staff and data about patients. And in many hospitals, including my own regular hospital, we often didn't bring this data together until a long time afterwards, and also perhaps at a committee that feels quite far removed from the staff. But in the Nightingale, all of this data was really looked at on a daily basis. The first piece there is quite novel. So that was called a bedside learning coordinator. And I'll just say a word or two about that if you go to the next slide. So the bedside learning coordinator was a role which we think was, yeah, that one, was novel, certainly to UK healthcare, not novel in terms of other industries. So very, very familiar. If people know Toyota, the BLC is the equivalent of the person who comes when you pull the Anden cord. So the premise of the BLC is that the staff have far too much on their plate to be thinking about codifying their insights and recording what's working and what's not working. And so you put somebody on the ward to be their eyes and ears. And it was very, very interesting to play this role, which I did myself on the first shift, because quite interesting, it's fascinating that staff who were NHS staff, and we had a mix of staff in the Nightingale who were familiar with the ICU environment, NHS staff who weren't, and people from outside the NHS. So they thought that I was perhaps some sort of inspector to check on them, rather than somebody there to record their observations, tell us what was working, little niggles through to larger things, and to make sure that that information from running the shift got out and fed into how subsequent shifts were planned. And remember that the imperative here is that we've got a new disease, which 100 days before this was not known. So we're far more familiar with COVID now than we were back in the end of March, April, when we were designing this. A novel workforce. So nobody has worked together before. You've got people from all over London. They are, many of them who are familiar with the ICU setting, are working in a different way. So we're working to a 1-to-4 critical care nurse to patient ratio versus the usual 1-to-1. And you've got many people who are simply unfamiliar. Think back to that picture before of the ward with the environment. So you can imagine how important it is to learn quickly. So the BLC, think of them as a way of hoovering up the insight that would normally just be lost, and making sure that that comes out and is fed into how care is designed. There was also, as you can see on the slide, a returning changes piece. So that would be a lesser part of the role, actually, but that would be things like doing little spot checks, working with people to see, do you know what the 3 key messages for today are? And if not, then coaching people in that, and making sure that those key messages are fed back into the ward. And I'll say a bit more about this, and we might discuss it in questions, but there are around a dozen sites across and around London that are experimenting with some sort of learning coordinator in the usual setting. If you go on to the next slide, so we'll keep on working our way around this this graphic. So we've done the first element of the learning system. We're getting the right data in, and then the quality and learning team, which was my team, was really where all of this information came together that evening, and was processed and triaged out to different places. So you can see the next feature would be these decision-making bodies in the middle. And the specialist decision forums in the Nightingale case was a mixture of a daily meeting for matrons, a daily meeting for workforce and people, a daily meeting for medicine, and a daily meeting for ops. And then there were things that were just for them to resolve. So remember the chairs. So for ops, it was people are writing on the OBS charts at the ends of the bed, and they're having to do it on the floor because it's all very low. So how can we solve that? So we ran around and got some chairs. So that doesn't need to go anywhere else. It doesn't need a quality improvement project. It's just get on and do it. But there were more complex things that needed multi-professional input and some consideration and decision. And those were taken at a daily clinical forum that we had at 4 p.m. every day. And that was an extraordinary meeting. I'll just take a minute or so to describe it, because we would all work different teams. There were about 15, 18 of them in a really big room upstairs in the conference center. And the way that regular work was done is you'd work with your team at the table, and then you just wander over. Didn't tend to make appointments or anything. You just did it all on the fly. And so kind of parenthetic thought, how could the way that we structure teams interaction lead to much quicker dialogue and less kind of dead cost from meetings and things? But anyway, the point is that every day at 4 o'clock, that room stopped. And we had reports from each team about essentially, what have you learned today? What are you focusing on for tomorrow? And where do you need help from others? And we went around all the teams on that. And out of that, we would then determine 2 or 3 things that we needed to take together and charter. So I'll give you a really early example of something that we took from here was the feeding regime. So the dietitians determined that the feeding wasn't working as planned. There was something about these patients that didn't seem to be usual. So we needed a different protocol for feeding. Plus, because of the supplies nature, remember we had all sorts of equipment, ventilators and things from all over. And some of their supplies were in fluid ounces from the US and some were in milliliters. And then the protocols were written in a mixture of both. And so that was flagged as a risk. And I think what would normally happen there is that it would be acknowledged and discussed and then taken away to be considered elsewhere, probably by different people over the next weeks or months, and it would go up to some committee. But here, they were asked, okay, well, who do you need on this team to work on this? Any volunteers for that as well? And half a dozen people went on to the feeding team, and they worked up a protocol. And the next day at the forum, a new protocol was discussed. So rapid decision making, I think, was really, really important, with bodies that were clear about what their authority was to make decisions. The last 2 boxes, the implement box on the right and the closure box, are rather more familiar, I think. So they were basically to run the tests or make the changes that we had said we were prioritizing, and then to verify that we'd done so. And if you go to the next slide, so we'll talk about category number 4 here. So you go to the next slide, you'll see this description of fix, improve, and change. And what surprised me about this, so over the course of the weeks the hospital was open, we had 400 odd lines of suggestion come out of the evidence synthesis and into the decision making. And around 2/3 of those were fixes. So these were, as I said, the chair's example, things that we had said we would do and we weren't doing, and things that we hadn't realized that we would need to do. I'll give you another example. So do you remember the sea of blue of PPE? So no one could identify who anybody was, and very quickly a fix there was to implement. Remember, we had the military with us, epaulettes. So if you were a matron, you had 2 yellow stripes. If you were a critical care nurse, you had 1 yellow stripe. Different badges for different people. Another example of the fix was there was no rest area in the ward, and we had lots of space, and we could easily put one in, but that surfaced by running the first shift and discovering that people told the BLC or in the structured debrief that that was something they needed. So my insight here, I think, or the message I took from this, was that very often in healthcare, people just learn to live with these things, or they find their own workarounds. Whereas what we were doing here was try to make a systematic fix to the way that things ran. And people found that invigorating. Also communicating to people where there were fixes that were coming, but not yet able to be done. So another example was clocks. So people couldn't tell the time. We hadn't realized that people wouldn't be able to tell how far they were through their shift. So we were able to say to people from day one, clocks are on order. It's Thursday today, they'll be here on Saturday. A word about improve and change. So improve is if you like, the standard PDSA or however you would run an iterative learning method towards a goal. And the day zero simulation came out of discovering that the staff who were not familiar with the ICU found that induction was no preparation for working in full PPE on the floor. So we moved to a system where people's first shift was on a mannequin adjacent to the ward, where we really tried to simulate the environment that they'd find themselves in with patients. And another way that we improved was the donning regime, which got immeasurably slicker through the course of the time the hospital was open. Lastly, the changes. So the fixes were about 2/3. The improve was about 1/3 of things, and the changes was just a little few things that were kind of major changes to our clinical protocols or models under substantial uncertainty. So the VTE protocol example there, or our extubation regime. So those were typically things that required quite deep multi-professional agreement about the way we were going to do things as Nightingale standard. If you go to the next slide, this is just one example from the Royal Free, from Chase Farm Hospital, of how this learning system is trying to be put into to practice in a regular NHS setting. So one of the things that Chase Farm has been doing is to restart elective surgery and endoscopy, and so their learning coordinator is not at the bedside in endoscopy because it's an ambulatory procedure, but you can see how the number of items raised, these in the top left, each of these is a week, and quite rapidly the number of items raised has been going down, which they don't think is because people aren't asking for things anymore. It's because you're moving quite steeply up the learning curve, and you can see on the right the sort of things that were being raised around processes, equipment, staff, etc. So I think the jury is still out, frankly, but the hypothesis is that these principles of learning can be embedded into regular work, and it's really invigorating for staff who want to make their life better, want to get better results for their patients, to stop them having to be workaround jockeys really in systems that are never going to get better, but more try to use their experience above all to improve the standard ways. And I just want to close, if you go to the next slide, by a word about teamwork. And I want to do that through introducing you to Aldis. Aldis I met on day one when I went to pick up my scrubs. She'd never worked for the NHS. She worked in gigs. She was due to be doing Glastonbury and the like, but obviously not this year. And she'd been made redundant and thought, what should I do? Her sister was a nurse in Scotland, and so she put herself forward to join the logistics team at the Nightingale. And Aldous is smiling in this photo, and there was never a time, frankly, when Aldous wasn't smiling. And she went through a series of jobs and promotions, and I believe is now working in a London hospital. But a couple of weeks after I took this picture, I said to Aldous, how's it going? And she said to me, I have never felt that my work was more rewarding or had more purpose to it. And here's somebody who a couple of months before had never imagined that she'd be doing anything like this. And now she's making a career in the NHS. And the point there, and something that we really emphasized at Nightingale, was that we were one team. If you look at the tweets from Nightingale, that will have the hashtag along many of them. And I think very often we don't think about our team in broad enough terms, and we exclude people whose roles are critical. So genuinely, people in Nightingale thought that Aldous was as important to the care of our patients, and she was just as much part of the team as the doctors and nurses and physios and pharmacists on the ward. And I think that, again, is something that we should think about and reflect on for usual times. So I'm very, very grateful to you for giving me the chance to share Nightingale's story here with the Fab Academy. And if you just flick to the next slide, I will pause there with a message of thanks. This is the Victoria Station board, and I used to walk a couple of mornings a week as I took the children to their emergency school through an empty Victoria Station just before 9 a.m. And it's quite something, really, to go through an eerily quiet station on a weekday. And it's even more of something to see that sort of thing about the place that you work and the work that you're doing, and your children to be commenting on it to you about how proud they are. So I just wonder how we can bottle some of that spirit and some of those principles of learning and play them into care in regular times, in regular settings. Thank you.
Hi, James, it's Lou.
Hello, Lou.
Hello, that was brilliant. Thank you very much. I just wanted to ask, how was this designed in terms of the learning systems that were built in? How was that designed? And was the system itself tested in the way it was run? And what would you suggest to other people that wanted to build that kind of learning system into their organizations in normal life?
Yeah, great question. So I mean, everything in Nightingale was done, perhaps not surprisingly, at extraordinary warp speed. And I think the learning system itself was designed like the philosophy it was aiming to promote, iteratively. So we had a fantastic little team with some amazing people on it. I won't single out any of them, but we're still closely in touch. And we just, the commission we were given, if you like, from the medical director and the director of nursing and the COO was, can you make sure that we've got some QI in the Nightingale? And we realized that actually that probably wasn't going to go fast enough, that somehow we had to make an environment that turned everybody into an improver by kind of unlocking their ideas. And that's, I think, what great improvement is, isn't it? It's staff thinking about, what matters around here, and how do we decide on some things to test and then have a way of testing them. So we tried to build that into the DNA of how the place worked. So to answer your question about how the system was designed, it started with some principles around learning quickly, and some hunches that we had in the team for how you could build that into ops. I kind of think, all of us who are improvers and not operators, if you like, the hats that we wear, we're constantly trying to find ways to put more improvement into an already there operating system. So we had the luxury that there was no operating system, and we basically, made the two the same thing. But it went through a whole series of changes. That diagram that I showed you probably was about version 20, to learn how do you sequence the matrons meeting into the clinical forum, how often does it have to happen, how do you get the data flows right. So absolutely, that was designed by iterative learning to the goal of how on earth can we learn as fast as possible to keep these patients safe and look after our staff in this pretty horrendous situation.
Thanks very much, James.
One thing in closing, I talked a bit about the learning coordinator, and a number of people are trying out that learning coordinator role. I would just give anyone who's thinking of trying that out one little suggestion, which is think about the learning coordinator role in the context of a wider learning system, because I think there is a risk that if you put in a learning coordinator, which is often the bit that people home in on when we tell this story, you run the risk that you're just going to catalog stuff, and you're not going to have a way of closing the loop and making the suggestions get acted on. And that could be a recipe for frustration or worse. So I would really encourage you to share the learning system outline with your colleagues. We can tweet a paper that we wrote about it if that's of use to anyone. And do try this at home, but do think of it as a whole system rather than just the learning coordinator. Thank you.
Great. Thank you so much, James.
Thanks so much, James. That was really, really interesting.
Have a great rest of day.